if there's any questions, hi everybody, it's Alex Grichuhin again. If there's any questions with in regards to lung health, heart health, anything like that, specifically with rehabilitation, if you want to go ahead and ask some questions, please by all means ask a question. And I will go over just a few of these questions that got brought up. First is, okay, when working out with a patient or physical therapy, we like to keep patients from 40 to 80% or a MET level, that's the metabolic level, of about 2.5 to 5 for about 15 minutes based off of maximum heart rate of 220 minus the patient's age. Good morning. So when we look at cardiac rehabilitation, there's a couple things that we always want to look at. Is, when we strive to rehabilitate somebody, first off, what does that rehabilitation mean? So when it comes to rehabilitation, what we look at as far as rehabilitation is, first we have to look at what the diagnoses are, and looking at the proper care plan to help that person out. So everybody, even though the disease might be the same, everybody is a little different. So anyways, if you have any questions, please write them out. I'm going to grab something really quick. Excuse me, one quick second. Sorry, duty calls when somebody, like a doctor calls me, I have to kind of respond. Anyways, so I apologize for the wait. All right. So we're looking at, mind you, if you have any specific questions or anything like that, I'll be happy to address them. All right, so when working out with a patient or physical therapy, we're talking about cardiac rehabilitation right now. We like to keep the patients around 40 to 80% or a MET level of about 2.5 to 5 for about 15 minutes. Now, what does that mean? What does that mean that we want to keep somebody at 40 to 80% or a MET level of 2.5 to 5? So MET levels, we look at the metabolic levels. We look at more closely when we look at somebody with different types of complications, specifically with cardiac rehabilitation, or with heart complications. So we take 220 and we minus the person's age. So we take so let's say you want to do a cardiac exercise, all right? First is you don't ever want to do an RPE very high yet, which is the rate of perceived exertion. So you don't want to go too fundamentally high with that person. So what we like to do is we look at the person's age, and then we take a number like 220, which it's always 220. 220 minus the person's age. So let's take, for instance, somebody is 85 years old. Take 220 minus 85, that's 135 beats per minute. Okay, then they want to stay at 40 to 80%. So if somebody was 85 years old and their maximum heart rate, which is the 135, because I took the 220 minus the age, and the age we're just pretending as 85 years old, that person should have a pulse rate range of 54 to 107 beats per minute. Now, what if you take somebody that is in cardiac rehabilitation, but they have a dramatically high heart rate? If that person has a very dramatically high heart rate, like a chronic high heart rate that is tachycardic, and let's say that person's heart rate they're 85 years old, but that person's heart rate resting is, let's pretend 120. Let's just say 114. And they're trying to stay within a range of 54 to 107. Okay, so how do we work that out? Let's say somebody already has that is already tachycardic, meaning that their heart rate normally is above 100 beats per minute. So in that case, we have to rehabilitate the heart. And eventually with the exercise and tolerations to the exercise, that person's heart rate will start going back down to a good normal level. Right now, the heart's working really hard, let's say. So as we implement cardiac rehabilitation, we have to keep everybody safe, of course. So we'll look at blood pressures. We'll look at blood pressures, oxygen saturations. We'll look at ECGs. We'll look at everything while the person's exercising. And these are things that are all done virtually. So even though like you have an ECG, we ship you out something that somebody would, put their two thumbs on, and it's FDA approved. They'll put their two thumbs on, and it will be identical as going into a hospital's using their ECG, or EKG. But in this case, it's a 12-lead ECG when we do when we look at the data. Okay, so now when somebody's asking me, what's a MET level of 2.5 to 5? Well, we look at somebody and we say, all right. Well, you have somebody who can barely walk. Maybe they can barely breathe too, but they can barely walk very far. And we'll start working with that person, strengthen up legs and upper body, working lower and upper body. And then as we do like tests, like 6-minute walk tests, CATs, different types of tests to help us understand what that person's major problem is. Is it heart related? Is it lung issue? Is it both? And usually in about 3 to 4 weeks in, we start getting a better idea of how to help this person out even further. So it's the worst thing you could ever do is just put somebody into therapy and assuming they're just like everybody else. with their diagnoses, that that each and every single one of them has a bad hip, let's say. It's the worst thing you could do. When you strategize, you're being strategic about your therapy program. You don't want to just jump into a gym. Like I saw some people on Facebook saying, well, I want to join a gym. Well, that's great, but that's not going to help unless you actually have a clinician helping you, because it's you always want to have some type of peer review, when somebody is helping you with rehabilitation. But the worst thing somebody could do is just, like, let's say somebody has a really hard time with breathing and they jump into pulmonary rehab, right? Or that person just joins a gym. Okay, so let's say that person just joins a gym. All right, so what are you going to do in a gym that's going to help with your breathing? Because walking is not necessarily working on your lungs, it's working on your legs. Of course, there are some benefits with like walking on a treadmill or using a bicycle, but you're not helping the breathing part because there's no respiratory muscle training involved. Okay, so yeah, that's what I mean by peer review. You always want to have some type of peer review where you have a clinician who is licensed in that field of study, and then that person oversees what you're doing. As you're working out, that person sees you, you see that person, vice versa. Works like a two-way mirror. And then basically, let's say your goals are to come off all these sorts of medications, come off oxygen, and that's what we strive for, is we get somebody who can't do a lot to getting them to do a lot more. But when they go back to their cardiologist or their pulmonologist, depending on their disease, if they go back, we want to see the results of what that doctor found with our focused on transformation. Some people ask me, what does transformation mean? Of course we understand the wording of transformation, you're transforming, but a lot of times when you go into a facility that's certified, you look at, let's say somebody goes into a rehab program and they feel the same way as they come in as they leave. Okay, that's what we call maintenance therapy, where we keep people the same. We don't do that here. What we like to do is get somebody in the program that can't do a lot, and then getting them to do a lot more. So they're transforming. They're changing their overall disease into a better disease state, in a sense. So we're not curing anybody. What we're doing is we're just helping that person out, getting them to a point where they won't need us ever again. And that's what we look at in with cardiac rehab. By the way, if you have any questions, just write in the comments section. I'll be happy to answer them, specifically for cardiac and pulmonary rehabilitation. All right. Let's see. Okay. Another question arises is a lot of patients want to wait until they join a rehab program. That's one of the worst things you could ever do. The worst things you could ever do. From my expertise, which is it's pretty vast, as well as all the other doctors we ever work with, which are tremendously a lot of doctors. The worst thing you could ever do is wait. It's the worst thing you could ever do is wait. And there's always a million reasons to not do something. Okay? There's always going to be a million reasons not to do something. So if we can get that person in and work on them right away, it's a better prognosis. We're looking at 6 months down the road versus the person waits because they have all these other adult obligations they have to do, which we understand. But this is your life. And waiting or procrastinating is just going to make it worse. Okay? I would say one out of 10 people that wait the longest, I'd say 1 out of 10 people that wait the longest usually will get lucky, and they'll wait a very long time before they enter the program, but they're basically walking on eggshells at that point. That person at a 1 out of 10. 9 out of 10 that usually wait the longest. I think you'll understand what I'm trying to say. The longer somebody waits to get their health back, it's the worse it's going to be, because you're talking about progressive diseases, especially with the heart and lungs, which are vital. You know, they're major organs that either you live or you die. If they don't work very well, you just don't. You're just not going to function very well. So, anyways, if you have any questions, please write them up in the comments section. I'll be happy to answer them. With heart disease, we usually find a lot of increased work of breathing, especially with congestive heart failure. And working with somebody's breathing has nothing to do with somebody's lungs, in a sense. It's the heart's not functioning well. So when we look at somebody's heart, you know, just because you get oxygen into the lungs and then that oxygen transfers over to the blood, just because the oxygen content is in your blood doesn't mean it's getting moved around or pushed around, circulating around the body for the oxygen to be pushed into an organ. Okay, people don't realize blood pressure has a lot to do with that. So atrial fibrillation is not necessarily a blood pressure problem. Okay, it's the circulation problem. Okay, so you know, one of the things with increased work of breathing is specifically with cardiac. It can be from the heart not functioning well, and it's not pushing the proper oxygen around as well as it should, or it's the blood pressure is very, very low, which in that case the content of oxygen stays high in the blood, meaning you put a pulse ox on and your pulse ox read 99%, let's say 100%. Most of the time we're thinking something's wrong. That's not a good thing. That's not usually a good thing, even though it's still considered normal. You have to understand that if the body's always pulling out oxygen and the content, like its supply, is in the blood, but the supply in the blood stays very high, that means the body's not pulling any oxygen out of the blood. Okay, if the blood was being if the organs were pulling out the oxygen, the content or the percentage wouldn't be very high. Okay, it's not rocket science. You know, so you have the supply of oxygen in the blood. The organs pulls out what it needs. Okay. So let's just pretend, even though this is of course fact. Let's say 100% came into the body, and then you measure on your finger, which is the last site of before the blood circulates back over to start the process all over again. So let's say you have 100% oxygen coming in, and you have 100% left over because you measure on your pulse ox. Pulse ox is not located on your lungs, not located on your heart. It's located on your finger. You're measuring on an extremity. Okay? If 100% is left over, that means nothing was pulled out. Do you understand? So it means nothing was pulled out of the body. Okay, 100%, unless the content or percentage is extremely high. Like you're talking about an FiO2, a fraction of inspired oxygen, being as high as, 60, 70%, which the atmospheric oxygen is 20.95. Okay, or we like to say 21% of oxygen in the atmosphere. Okay, but that's called FiO2, fraction of inspired oxygen, 21% in the atmosphere. So the body's supposed to be pulling this oxygen in, but the content or the percentage is very, very high. Needless to say that, first off, oxygen is not what causes out of breath. It's the CO2 that causes out of breath, for people that don't know, But as we do, proper rehabilitation, we focus on these weaknesses or these problems and getting them to be resolved, in a sense. A lot of people always ask me what types of medication would be best. Okay, so I'm pro medications. We're all pro medications here. A lot of the doctors here are all pro medications, but you have to understand we like to see if the body works itself out without the use of medications. Okay, some medications will help, of course, yes, but we like to see if the body will actually work on its own without the need of medications. So it's not like we don't want to use any oxygen, or any other medications, and oxygen is a medication, okay? Especially when you're looking at higher liter flows of oxygen. Oxygen is a medication, okay? Because too much oxygen will kill you. For those that don't know, you shouldn't be breathing in just pure oxygen. That's ridiculous. Like if I walked into a chamber of pure oxygen only, Nothing else. No nitrogen, no helium, no xenon gas, no nothing else, even though xenon gas doesn't really do anything. But anyways, I go into a chamber filled with pure oxygen, my lungs will start collapsing. It's a condition called absorption atelectasis. Okay, too much oxygen because there's not enough nitrogen will collapse the lungs, and then of course I would die. And if I didn't die from my lungs collapsing, then basically my heart will start slowing down too much. Okay, as it slows down because too much oxygen is coming in, because I'm breathing in pure oxygen, then my heart rate will obviously slow down. And how do you get CO2 from the legs or the brain or anywhere else to circulate to come out? Well, the heart does that. So if it's slowing down, then no matter how fast you breathe, you're not going to be breathing out enough CO2. And of course, you'll go to the hospital with acute and chronic respiratory failure if you're lucky, okay, with too much. Let's see, Rex, not sure if this is VOD or actual live, but anyways, if my oxygen stays reading at 99, should I take my cannula off for a minute or two? So at 99%, remember, it depends on what you're doing, Rex. So this is live, by the way. Let's say I'm sitting down, my oxygen is 99%. That's fine. But let's say I'm standing up, and now my body's going to consume more oxygen. Okay? If it's going to consume more oxygen, which is great, then my levels of oxygen that is 99 will try to dip down a little bit because now my body's utilizing that. It depends on the exercise itself, what you're doing. If you're staying at 99%, according to American Chest Physician guidelines, anybody who's at 95% or higher should be titrated down, but you don't do that. The doctor or clinicians would be doing that. That's on your case, not you specifically, because we want to look at worst case scenario basis. We want to look at somebody exercising with oxygen or even without oxygen and seeing how well that person does. Good morning. For months, my shortness of breath has been getting worse. I've asked you about it because I quit smoking 6 months ago, and you said it was part of the healing process. That is true. When you stop smoking, the lungs will start to stiffen up because now it's healing and causing more fibrotic repairs and more dense lung tissue. So the lung parenchyma, which should be elastic, will start hardening up a little bit, making it a little difficult to breathe. Now, so my pulmonary doc did in the in-depth breathing test, gave me a B- and said my lungs sounded clear. Now he has ordered a CT scan. I can't live this way. I am getting so frustrated. Okay, so D, you're doing this blindsided, meaning, the thing that people should be doing is sitting there. First off, there is no medication out there that it will ever exist to fix stiff lungs. Okay, that's something that's just going to get worse until it completely solidifies in a sense. But your lungs won't technically solidify like concrete, but it'll make it feel harder to breathe. Okay, but you're doing this blindly, where you're probably looking things up, and I don't mean this in a bad way, D, but you're probably looking a lot of things up online of what to do about this, and that. The reason why, that information is kind of grotesque and not really good is because you don't have a clinician that's working on you. You have your doctor, but your doctor didn't major in, your doctor never majored in pulmonary rehabilitation, okay? There is no doctor that does that. Okay, so you go to specialists like somebody like me that works on pulmonary rehab, that specifically works on your lungs. Those are the people you should be talking to, like you're talking to me right now. You're talking about your lungs are getting stiffer, which I can see because of the healing process because you stopped smoking. Where's your respiratory muscle training exercises? How many times are you doing it? Did you have me look at you while you were doing it, to make sure you're doing it correctly, just so you're not blindsided? So the best advice I can ever give you is see me. Call in and just make an appointment. We'll do it through Zoom. Just see me. That's it. It's one of the best advices I can give you because maybe you're not doing respiratory muscle training at all. I don't know. I mean, I would like to see the actual therapy and technique that you're using. But if you're doing respiratory muscle training the correct way, you wouldn't be having any questions, nor would you have these problems with increased work of breathing. They would have been resolved already. Do you understand what I just said? They would have already been resolved. Okay? You're asking for help, and I'm giving you help. But there's, it takes two to tango, right? So if you need that help, then come in and get the help. Your doctor can recommend pulmonary rehab, sure. But I would say no, because no one ever told me. Yes. Well, I mean, we state that every time we go live that you should be joining into a pulmonary, that have breathing issues should be joining into a pulmonary rehab program, and there's nothing wrong with any pulmonary rehab program, but, would you rather go with a pulmonary rehab program that has a much higher success rate globally? Okay, HRN has the highest success rates, but that's because we're specialized clinicians. Or would you rather go with somebody with an 11% successful rate, which is the national average, okay? We average at 98% success, okay? Success rates are based off of the person's ability and, of course, the goals the person sets in, as long as they're realistic. If somebody said, I want to be able to run a marathon, and they can barely walk 10 feet or let's say, then that person's probably going to need a little bit more time to be able to run a marathon, But yeah, it's best to call in if you need that help. Call in. I mean, it just sounds like there's just a lot of guessing work, and guessing doesn't help anybody. Okay? Because it just makes, the assumption is usually the mother of all mess ups, right? So we don't like to assume anything. Okay. All right. So on a Borg scale, that's B-O-R-G, Borg scale. So what does a Borg scale mean? That's a subjective number. We use RPE, we use CAT scores, we use Borg scales, talk tests. No problem, D. Thank you very much. So we use scales to determine how out of breath somebody is. So for instance, let's say somebody says, Alex, I'm very out of breath. I ask them, how out of breath are you? And that person says, I'm at a 9 or a 10 out of breath, and with 10 being the worst. And I said, then how are you able to talk? He says, well, I don't know. I don't know how I'm able to talk. What I'm trying to say is that if the person was legitimately at a 9 or a 10, they couldn't say one single word. They'll be, they can't even catch their breath to talk. So people probably don't even understand that their 9 or a 10 might actually, depending on a talk test or according to a talk test, if somebody can say 3 or more words without having to gasp for air, like they can say, my breathing is manageable, and they didn't have to struggle to say that, then that person most likely is at 4, 5, and 6. They may feel that are 8, 9, and 10 on a Borg scale, but their anxiety might be at an 8, 9, and 10, not their actual work of breathing is, So we always look at a talk test, Borg scale, it's a subjective number. If you're working out at a Borg scale of a 1, meaning you're not going to be winded whatsoever, you're not feeling winded at all, you might not get a lot of success out of the program, because you're not doing enough to increase that work of breathing to tolerate higher levels of activities or exercises. I see a lot of people, when they go into a gym, they'll walk on a flat surface and they'll just keep their work of breathing very easy. And they're wondering why I can't go upstairs. I exercise for 30 minutes on a treadmill. I can't do this. I still can't do that. And I said, because all you're tolerating is very easy. You're not tolerating hills. You're not tolerating stairs. You're not tolerating higher endurance levels. And in order to do that, it's, you're trying to get somebody who needs to walk or even jog. You're trying to get that person to tolerate that. So the worst thing they could do is stay at a Borg scale, an RPE, or an RPE, rate of perceived exertion, of a 1 or a 2. It's just not going to be enough. You're not working hard enough to exercise at those levels and tolerate those levels. So when we pick up somebody and we exercise them, we'll exercise them at a level of easy first, and then we'll slowly get them into around, a RPE or a Borg scale of a 4, 5, or a 6. But they'll only stay up to those levels, which is about 60 to 75% of the person's maximum heart rate. We'll only keep them up there for about 45 seconds, 30 seconds, and then we'll slow it back down. So let's say, well, I'll need to write it down. Let's say you're working out, and I'll have you do a warm-up for about 5 minutes, and then I'll increase the resistance or increase the speed. Okay, I'll tell you speed up, all right? And you're only going to tolerate that for about 30 to 40 seconds, and then you lower the speed down, dropping it back down to a comfortable level. So every 30 seconds, I'm going up for about 30 to 40 seconds, right? Drop my work of breathing down by slowing down. And then every 2 minutes, go up to those levels. The longer I can stay up to those higher levels, the better. Okay, if I stay at a lower level, meaning I'm not exercising very hard at all, I'm just going very easy, I'm only biking very easy, you might not achieve a lot. Okay, so everybody gets, when they come into this program, they want to try to get to point B, to graduation in like a few days. This is not a magic pill. You have to work at it. Anybody else have any questions? If that's it, then I will say I'll see for my class. I'll see you on Monday. On Monday will be some of the education, but we do have to, of course, exercise. So respiratory muscle training, bring your delta Vs, bring your incentive spirometer, your pulse oximeter, and it probably would be a good idea to also to bring some free weights too, and therapy bands if you have them. And if you weights, you can use water bottles, soup cans, anything like that that can provide a weight, and that should be just fine. Other than that, let's see. I have high blood pressure. I'll get nervous just knowing I need to take it, but doctor wants me to monitor it. Doesn't seem to get better. So remember, things don't get better unless can your program be done remotely? D, what are you talking about? This is a remote program. HRN is a home rehab. Rehab, meaning you do it home, and you use your phone or a tablet or a computer that has a camera on it, and then I can see you, and then you will be able to see me. It's always done remotely. Now we do have a physical place, but yes, the program can be done remotely, but that goes without saying. That's what we do. Oh, not enough coffee. Well, that's I come prepared a little bit. All right. So Nancy asked, I have high blood pressure, and I get nervous just knowing I need to take it, but doctor wants me to monitor it. It doesn't seem to get better. So again, we're talking about rate of perceived exertion. We're talking about a Borg scale right now. When somebody works out, when somebody's working out, they might, we usually find people depressed and very anxious when they come to the program, because they feel like, oh, there's no hope and stuff like that. When we don't strive on hope, we strive on results. That's what you want. You don't want to, I hope this works. It doesn't work that way here. It's either we do it or we don't. If you do it, you get better. That's the way it is. But Nancy, that's pretty common, especially when you have a lot of problems. It's pretty common to have that, So when you first come in, we work on some stress management, lower your anxiety down. We'll work on your breathing. We'll go very light, very slow, and then as you get better and better, we'll start adding more into your therapy program until you are achieving what you want, which a lot of people want to be able to walk further, come off oxygen, wean down on some of the medications, basically, just get their life back, so yes, absolutely. And yeah, finding anxiety, people anxious is pretty common in this program. Stay tuned for the Tuesdays and Thursdays. Tuesdays and Thursdays will be our live feeds on YouTube. Please follow us on YouTube, Twitter, Instagram, as well as on TikTok and Facebook and all that jazz. So we're trying to spread the word as much as we can, because we understood when we started that there's no other program like this. You know, there are other ones out there, but you want. All right, no worries. There are other programs, but are according to national studies, HRN does hold the highest one in success rates. So not trying to toot our own horn here, but this is what we do for a living, you know. So we do pulmonary and cardiac rehabilitation, and of course it's covered by insurance. Other than that, I will see everybody back on, remember, on Tuesdays and Thursdays we have our live feeds. Thursdays, I believe Dr. Shaw comes in and does his live feed with everyone to ask any types of questions or anything like that. So please stay tuned for that. We did have a cardiologist in here today, and we'll be uploading that video shortly. Okay? All right. Other than that, I'll see you guys later. Bye-bye.